Superior canal dehiscence syndrome. What is superior canal dehiscence syndrome? SCDS was first described in 1998 as a condition that occurs when the temporal bone overlying the superior semicircular canal is unusually thin or absent. A third opening is then formed between the superior semicircular canal and the middle cranial fossa. Instead of sound waves traveling from the oval window to the round window, waves flowing through the cochlea are inadvertently transmitted throughout the labyrinth system. Symptoms include vertigo induced by loud sounds, also known as the Tullio phenomenon, changes in pressure in the external auditory canal, autophony, which is hearing of self-generated sounds, hyperacusis, unusual intolerance to ordinary environmental sounds, pulsatile tinnitus, hearing a pulsing noise mimicking heartbeat, and of course, hearing loss. The figure on the left shows an image from a CT scan of what a dehiscence would look like. CT scans are a very important tool in diagnosing SCDS and are often the only way to truly confirm the presence of the dehiscence. On the right, you can see how fluid should flow normally from the oval window to the round window and how fluid would flow abnormally to the dehiscence. There are other disorders that mimic SCDS. The most common, perhaps, is patulous eustachian tube. Patulous, meaning wide open, refers to the fact that the eustachian tube often stays open, leading to heightened hearing of internal sounds common to SCDS. While these two disorders both present with symptom relief when supine, the main difference between them is that patulous eustachian tube dysfunction includes breath autophony. There are other inner ear defects associated with the third window. These include posterior canal dehiscence, enlarged vestibular aqueduct, cochleocarotid fistula, inner ear abnormalities in which the scala vestibuli opens into the internal auditory canal, and more. There are a battery of tests used to identify and confirm SCDS. One test is peritone audiometry. PTA is used to identify and classify existence, type, and degree of hearing loss through standard air and bone conduction. According to bands, audiograms will show air-bone gaps of 10 decibels or greater at lower frequencies, which is a mild conductive hearing loss, bone conduction better than 0 decibels in low frequencies, but otherwise normal hearing. Admittance testing is also used to test the middle ear once hearing loss has been established. Standard tympanometry is used, where positive pressure is placed into the ear canal and drawn out to negative pressure. Results will show that tympanometric peak pressure and compliance are normal, as well as normal acoustic reflexes. However, dizziness is often induced, as it often is during PTA tests as well. Another test used is vestibular evoked myogenic potential. This is a vestibular reflex test that's used in the non-dehiscence ear to evaluate function of the saccule and utricle. The cervical VEMP involves an inhibitory neural reflex pathway, while the ocular VEMP involves an excitatory pathway. It's reported that patients with SCDS frequently have lower than normal thresholds for cervical VEMP responses to an audible click or tone burst, and elevations in the ocular VEMP amplitude responses. Lastly, there are a multitude of treatments available for SCDS. Canal plugging and resurfacing is as it sounds, using tissue, bone dust, bone chips, and fibrin glue to plug the dehiscence and create a watertight seal. Round window reinforcement is a low-risk treatment that stiffens the round window to leave the oval window and dehiscence as the two main inner ear windows. Craniotomies are also used to get a more precise view of the dehiscence. And lastly, if these are not necessary surgeries, counseling may be used to promote avoidance of precipitating stimuli.